What's the differential diagnosis of a patient with a huge splenomegaly? Differential diagnosis will include a chronic myeloid leukemia, myelofibrosis, visceral leishmaniasis or Kala-Azar, and malaria, chronic malaria. Okay, how you can differentiate between them by history examination and investigation. This is easy. In chronic myeloid leukemia, the patient will present with fever, with sweats, weight loss, and abdominal discomfort due to the splenomegaly. Okay, but if this patient had myelofibrosis, he will have the same symptoms of fever, sweats, weight loss, and abdominal discomfort. Okay, so we see that history is not helpful in differentiating between chronic myeloid leukemia and myelofibrosis. But in leishmaniasis, fever and sweats only. Okay, there is no weight loss, and in malaria there is fever, which is periodic fever, characteristic periodic fever, and rigors. So we can see that history is not helpful in differentiating between the chronic myeloid leukemia, myelofibrosis, visceral leishmaniasis, and malaria as causes of huge splenomegaly. So we are going to proceed with examination. Okay, when you examine a patient with chronic myeloid leukemia, you will see that this patient will have a huge hepatosplenomegaly, okay, a huge splenomegaly and hepatomegaly. Okay, and we might find the patient is anemic and have some bruises due to low platelets. As you know, in chronic myeloid leukemia, there is abnormal proliferation and formation of new white blood cells. Okay, so there will be a decrease in production in platelets and in red blood cells. So there will be anemia and easy bruising on examination. But in myelofibrosis, there will be also hepatosplenomegaly and the bruising and the anemia, but characteristically there will be increased susceptibility to infection because there will be low white blood cells. But in leishmania, we have the hepatosplenomegaly and lymphadenopathy. So from this, we saw that the history is not helpful, but on examination, we can see that characteristically leishmaniasis has lymphadenopathy and myelofibrosis has infection. Otherwise, they have the same findings. And in malaria, we have the fever and the jaundice. So history is usually not helpful in differentiating. Allahu Akbar. History is not helpful in differentiating between chronic myeloid leukemia, myelofibrosis, leishmaniasis, and malaria, but by examination we can see that most of them have hepatosplenomegaly. The first three have hepatosplenomegaly, but the malaria has jaundice. Okay, so jaundice in malaria, but how to differentiate between the first three ones? The first three ones in the visceral leishmaniasis we have lymphadenopathy. Okay, so we have excluded. If this patient has no jaundice, we have excluded malaria. If this patient has no lymphadenopathy, we excluded visceral leishmaniasis, and then we just have the chronic myeloid leukemia and the myelofibrosis. This will need investigation. In chronic myeloid leukemia, the first thing, if you have high white blood cells, this is chronic myeloid leukemia, and you just need to do a neutrophil alkaline phosphatase score, which will be low, and Philadelphia chromosome, which is B positive in 80% of cases. If it's negative, it doesn't exclude the diagnosis, but it indicates that this patient, if he has chronic myeloid leukemia, he will have worse prognosis. In myelofibrosis, we are going to do if the white blood cell is low. So you are going to think about myelofibrosis. If the white blood cell is low and the patient has no lymphadenopathy and no fever and jaundice, so we have excluded chronic myeloid leukemia and visceral leishmaniasis and malaria. So if this patient has low white blood cell count and we have excluded the other differential diagnosis, we are going to do a blood film, and by this blood film we are going to see leukoerythroblastic cells in the blood film and teardrop cells in the film. This is characteristic, but the diagnosis will be by a bone marrow showing fibrosis. So this is a simple way to go through the differential diagnosis by history examination and investigation. So in summary, in chronic myeloid leukemia, you have the patient will come to you with fever, weight loss, sweats, and abdominal discomfort due to the splenomegaly. You might have the same symptoms in myelofibrosis and symptoms of fever and sweats leishmaniasis without the weight loss and the abdominal discomfort. Okay, even though there might be abdominal discomfort, but the characteristic very huge splenomegaly is present only in the first two, chronic myeloid leukemia and myelofibrosis. Okay, so fever and sweats and leishmaniasis. And malaria, they have periodic fever and rigors. Okay, periodic fever and rigors, and the patient might tell you that he have history of foreign traveler. Okay, so we can see that they are very close to each other in history. Both have fever, the sweats, fever, sweats, fever, sweats, but the chronic myeloid leukemia and myelofibrosis, they have the weight loss. So they are not that helpful, so we are going to look for the examination. All of them have the hepatosplenomegaly. Okay, all of them, they have the hepatosplenomegaly, but what is characteristic that the chronic myeloid leukemia, the myelofibrosis, they have anemia and bruising. They have the anemia and the bruising, but the other ones, they don't. The leishmaniasis and malaria, they have not the anemia and bruising. But when you check for your patient, he might have infections. He might have increased susceptibility to infections in myelofibrosis because of the low white blood cell. In leishmaniasis, the characteristic lymphadenopathy, and jaundice and malaria. So when you are examining the patient, if your patient with splenomegaly, he have jaundice, think of malaria. If he has lymphadenopathy, think of leishmaniasis. If you have increased susceptibility to infection, think about myelofibrosis. If he have none of this, think about chronic myeloid leukemia. Then about in the investigation, if the patient has a white blood cell count, chronic myeloid leukemia, this definitely is a chronic myeloid leukemia. You just need to confirm by the low neutrophil alkaline phosphatase and the Philadelphia chromosome. If this patient has a low white blood cell count, this might be present, okay, in both of the myelofibrosis, leishmaniasis, and malaria. Okay, or low white blood cell count, you should do a blood film. If in your blood film you have thick and thin blood film, you have evidence of malaria, this is a malaria. If in the blood film you have leukoerythroblastic cells and teardrop cells, think about myelofibrosis and confirm by bone marrow showing fibrosis. And regarding leishmania, bone marrow or biopsy or leishmania or spleen for leishmania Donovan bodies. Okay, and thick and thin blood film for malaria. So briefly, chronic myeloid leukemia, the patient will have fever, sweats, weight loss, and he will have hepatosplenomegaly, anemia, and bruising. And on investigation, high white blood cell, characteristic high white blood cell, and the Philadelphia chromosome. In myelofibrosis, the patient will have a history of fever, sweats, and weight loss, and he will have the hepatosplenomegaly and increased susceptibility to infection. He will have a low white blood cell, not as the chronic myeloid leukemia. He will have a low white blood cell, and in blood film you will have teardrop cells and bone marrow fibrosis. In leishmaniasis, fever and sweats, we have the hepatosplenomegaly with the lymphadenopathy, characteristic lymphadenopathy. But in investigation, low white blood cells also. But in bone or spleen biopsy, you will have leishmania Donovan bodies. Malaria, we have the fever, which is periodic, characteristic fever, rigors, and history of traveling, and on examination, characteristic fever and jaundice, and thickened blood film are diagnostic. Okay, now what's the treatment? In chronic myeloid leukemia, the treatment is by giving IV hydration, allopurinol, and imatinib. In myelofibrosis, treatment is supportive and transplant is needed. In leishmaniasis, treatment is by sodium stibogluconate, and in malaria, chloroquine is needed. Okay, what are the examiner might ask you, what are the indications of bone marrow transplant in hematological diseases? Take this with you. Bone marrow transplant in hematological diseases include acute myeloid leukemia, chronic myeloid leukemia, acute lymphocytic leukemia, and myelofibrosis, myelodysplastic syndromes, severe immunodeficiency syndrome, severe aplastic anemia, and non-Hodgkin's lymphoma. So, again, what are the indications of bone marrow transplant in hematological disease? Those include acute myeloid leukemia, acute lymphocytic leukemia, and chronic myeloid leukemia. You can see that chronic lymphocytic leukemia is not present here. So acute myeloid leukemia, acute lymphocytic leukemia, and chronic myeloid leukemia. Others include myelofibrosis, myelodysplastic syndromes, severe aplastic anemia, severe immunodeficiency syndrome, and non-Hodgkin's lymphoma. Thank you for watching.